Great. So hello everybody. My name is Chris Jenner, Dr. Jenner. I'm a consultant in pain medicine. What we're going to do today, it's a webinar basically on some of the report writing for reports in pain medicine. So what we thought we'd do is we'll go through some of these slides to start with, and then hopefully that'll be done in about half an hour or so. And then I thought really collect up all your questions, and then we can go through a sort of question and answer session at the end, and that's probably, people find that most helpful. If we start off, pain issues. Well, what are some of the pain issues that we look at? Well, we do personal injury, and increasingly we do clinical negligence. When we're looking at personal injury, a lot of the cases that we get are musculoskeletal, and out of that, I would say the vast majority are lumbosacral pain, lower back pain. That's often associated with lower limb pain as well. And also we get a large number of cervical spine or neck pain problems and the aftermath of that. So they're the two major issues that we see in musculoskeletal pain, and it tends to be the skeleton, it tends to be basically the lower back and the neck. The other thing we see in personal injury is neuropathic pain, and this is nerve pain where there's damage and or dysfunction of the nervous system. And the three major issues that we see there in personal injury are CRPS, which is complex regional pain syndrome, post-amputation, and fibromyalgia syndrome. Now, complex regional pain syndrome, CRPS, is always topical. We view it as a type of neuropathic pain. It can occur after relatively minor injuries, even anything from a sprained ankle or a sprained wrist, up to a fracture, up to a sort of twisting or other similar injury. And what happens is the patient develops nerve pain, usually in one limb to start with. It's very characteristic, and we use something called the Budapest criteria to try and delineate if patients have CRPS. They have very odd symptoms, really. They have hypersensitivity to light touch, to pinprick sensation. They have swelling, they have colour changes. They may have nail changes, hair changes, trophic changes. They may display tremor or abnormal movement of the limb, and it's quite a visual, as it were, pain condition. On top of that, the patients complain of very, very significant pain. They have very high pain scores, and as we mentioned before, hypersensitivity in association with that. Next one is post-amputation pain. If people have been in road traffic accidents, for example, and they've lost a limb, the main issues that we see in post-amputation pain, patients will get phantom limb pain, so pain in the limb that's essentially been amputated. Why? Well, because all the pain signaling pathways are intact even though the limb is missing. We will see post-amputation or phantom limb sensations. So patients will talk about the limb concertinaing, moving up into the body or moving around. And the other problem that they have is stump pain, and the stump pain can be a little bit musculoskeletal, i.e. when they put on their prosthesis, it can be locally unpleasant or locally painful, or it may be that they have a localized neuroma, or they have a localized area of neuropathic pain, for example, around the amputation stump scar. Fibromyalgia syndrome, we tend to look at this as a type of neuropathic pain, and we're going to talk about these conditions a bit further and the range of opinion on them later. But generally it's held that fibromyalgia syndrome, it's looked at as a type of neuropathic pain. Now, the difference between this and on pretty much all pain conditions is when you talk to patients with fibromyalgia syndrome, they describe all over body pain, and that's the one key difference between it and most of the other pain issues. So when you're faced with a patient who says, you know, well, where's your pain? Well, pretty much all over my body, doc. It's in my arms, legs, neck, back, shoulders, etc. The first thing that you're starting to think of is this potentially fibromyalgia syndrome? Now, thankfully, the American College of Rheumatologists, the ACR, has a checklist, a bit like for CRPS, but for fibromyalgia, in order to help you diagnose fibromyalgia syndrome. And when I'm presented with a patient who I think might have fibromyalgia syndrome, like the CRPS, I will use a checklist. And that's very useful. It's useful diagnostically, but also when you're writing these reports, it gives you that extra information. It gives you that extra credibility to say, well, I have looked at the American College of Rheumatology, I've gone through the diagnostic criteria, and this patient fulfills it. The other symptoms that we look at in the fibromyalgia syndrome checklist are all over body pain, so we go through that, fatigue, sleep disturbance, and cognitive disturbance. Those are the major symptoms. In addition to those major symptoms, we also do a further checklist where we look at other things like diarrhea, hearing difficulties, memory difficulties, neurological issues, etc., etc. And in fact, with the American College of Rheumatology, with the old guidelines, there are about 40 different other symptoms which are associated with fibromyalgia syndrome. And then basically, once you've done the checklist, you get to the bottom of it, you add it all up, and then it's a case of, is it, on the balance of probabilities, is it likely or unlikely that this patient has fibromyalgia syndrome? So very much the CRPS, complex regional pain syndrome, and fibromyalgia syndrome are essentially based on clinical criteria rather than on tests, blood tests or radiological tests. If we briefly talk about clinical negligence, obviously this we're finding is the fastest growing sector in medico-legal work. Again, yes, we do have musculoskeletal pain, but mainly a lot of it's neuropathic pain. So we see a lot of pain after surgery. We can refer to that as post-surgical neuropathic pain, where people have had an operation and then they develop neuropathic or nerve pain in the area where the operation has taken place. Hello? Can you hear me? Adam? Adam? I think I'm just going to have to assume that you can all hear me, but I will ring Adam at the same time. Okay, so the report writing process. Right, so this is very important. how do we go about this? Well, first of all, we start with the pre-assessment process. So before right, so before I see any of the claimants, basically what I do is we send out a pain questionnaire to all the claimants before I see them. It's usually sent out about a week or 2 weeks in advance. And the pain questionnaire has a number of different questions on it. Really, we're doing a pain history. So we ask about site, character, duration, radiation, aggravating associated factors, what medication is the patient on, what sort of benefit do they get from that. We also send them pain scores, so we get them to fill out the brief pain inventory, the Leeds assessment of neuropathic symptoms and signs. We get them to fill in some diagrams, so we give them a blank diagram of the body, and we get them to fill this out and sort of put labels on it as to where the pain is and shade it and that sort of thing. For the assessment itself, this is obviously face-to-face, and generally I've already got the patient's pain questionnaire back, and I've got a good idea of what's going on. So first of all, we start with identification, make sure that we have the right person. And really, during the time that I see the patient is really, I would say about a third to half of the assessment is a targeted examination, and that's really important. We do a general examination, and that's sort of things like gait, height, weight, body mass index. Do they present as disabled, not disabled? Who have they come with? What was their journey to the assessment, etc., etc. But then we'll do a targeted examination. So, for example, this may be a targeted examination of the neck, targeted examination of the lower back, targeted examination of the limb, whatever it happens to be. And the way we examine patients is the way we examine patients generally in medical practice. So that's inspection, looking at the patient, looking at the area; palpation, that is laying hands on the area; and then any special tests using light touch sensation, pinprick sensation, reflexes. I will measure the circumferences of limbs, for example. The other thing that I tend to do, for example, if a patient has an area of neuropathic pain, I'll take a skin marker, a surgical skin marker, and I'll ask the patient to delineate where the problem is, the pain problem is. And then I may photograph it, and I'll certainly take pictures of the relevant areas that I'm examining, and label them if necessary. I find that that's particularly helpful in a medical legal report. For example, if you're trying to describe someone as having neuropathic pain, let's say in their leg, to have a picture of their leg and surgical skin marker on it with outlined, showing you exactly where everything is. That would be good. Sorry, just getting a message here. Yeah. I need to. Where are we? So neuropathic pain, CRPS, post-amputation, again, all of those things I would basically do a targeted examination, and I would photograph the area and that sort of thing. Next thing, moving on, is a detailed interview. Now, what I tend to do with this is I have a number of questions which I go through after I've examined the patient. Now, a lot of these questions have been posed to the patient during the pain questionnaire process. And these are things like pre-accident, accident, post-accident, current pain issues, psychological issues, current medication, adverse effects, previous treatment given, sleep, weight, employment, pre-accident, after the accident, living situation, family and relationships, all the usual stuff, just to finish off: function, personal care, cooking, laundry, cleaning, etc., care requirements, household modifications, social life, financial benefits, hobbies and interests, all of those sorts of things. Now I'm just going to try and okay. So the next part of the report writing process is review of documentation. Now, what I tend to do with this is, first of all, it's looking through all the medical records. So we look at oh, hang on, Adam. So we look through the pre-index accident medical records is probably the first thing, and we look at I look through those in detail and summarize those. We then look through the post-index accident medical records and review all of those. Witness statements. So if you get witness statements, we'll summarize those. And then the third thing really is the expert witness reports, which we'll come on to. And the expert witness reports, that's very important. We'll talk about that in a little while. If I sound a bit disjointed, it's because I'm getting no feedback. So I'm sitting here talking into a computer, and I know there's some people there, but I can't quite tell. But my colleague Adam tells me it's going all right, so I'm just going to keep going. Now, next thing, biopsychosocial model of pain. Now, you've all heard this. What the heck does it mean? Right, well, it's relatively straightforward. When patients present with pain, they don't just have pain. We need to use this so-called biopsychosocial model of pain. So bio is biological pain. So we look at the fact that, do they have pain, yes or no? If they do, it's probably biological organic pain. So part of their pain experience is the fact that they actually have some pain coming from a structure. It might be from the neuropathic pain, it might be from the musculoskeletal pain, the neck pain, the lower back pain, whatever it has to be, or happens to be. But there's an actual cause, an actual source, as it were, of biological pain. The next thing, the psychological and psychiatric factors. Well, there are a number of factors that are associated with patients having an increased experience of pain. So the main ones are things like depression and anxiety. And when we do these reports, it's very noticeable that a lot of patients do have anxiety and depression, but also you may find other factors generally picked up in the post-index accident medical records. And hopefully, if they've been seen by an expert witness in psychiatry or psychology, these things will have been picked up, such as PTSD, post-traumatic stress disorder, adjustment disorder, somatization, mood disorder, etc. So the importance of a patient's psychological or psychiatric issues on a background of them having pain becomes incredibly important. The other thing, social factors. Well, usually the social factors revolve around some of the following. The patients have difficulty in the workplace. They may have lost their job. They may be on sickness. Excuse me. They may have difficulty at home functioning. They may have relationship problems with their kids, financial difficulties. We see patients who get into debt after the accident, which makes them stressed, which kind of feeds back into the psychological issues. They may have difficulties with intimate relationships. They lose their hobbies, they lose their friends, they generally become more miserable. So, you know, if you take it in its entirety, you can actually look through the patient and say, yeah, they had this accident, They had nothing beforehand. Now they have this nasty neck pain radiating into their arm. So they have a biological or organic reason for their pain. But now psychologically, say they've got a low mood, they may have been diagnosed with an adjustment disorder that may amplify their experience of pain. And then on top of that, they may have lost their job, their partners left them, they're experiencing financial difficulties, etc. And of course, one of the big ones is the fact that they're within the medico-legal process and the stress associated with that. So it's really, once you start to combine all of those factors, that's where you get a much better overall impression of the impact of the pain on that particular individual. So let's talk a bit about causation. So if we think about causation, the first thing I start to think of when I'm looking at causation is, do we have any other expert witness reports? Now, I'm bearing this in mind because generally a pain report is not one of the first reports that are done in these cases. It tends to be an initial report by a GP, then very often an orthopedic report. Other reports may be a surgery report, neurosurgery, general surgery, or surgery for the particular area. Sometimes there'll be a psychiatry or a psychology report. And of course, if all of those reports are already available before the pain specialist comes along, it really does help in aligning the evidence, to say, the claimant's been saying by the orthopedic surgeon, yet the expert opinion in orthopedics is that there has been an organic issue caused by the index accident, which is ... Likewise for surgery and for psychiatry and psychology, they'll be able to tell us, well, as a result of the index accident, the claimant has had a mood disorder or an adjustment disorder or whatever it happens to be. So having that information, if it's available, is extremely helpful. And again, it really goes back to alignment of the evidence. It's not about trying to fit the evidence with the other experts, but it's not more the fact that as a pain expert, we can be complementary, particularly with orthopedics and particularly with psychiatry and psychology, and we can somehow marry them up and say, the reason this person has this presentation, that there's good evidence for it, and here are the other experts' opinions and reports on that. Next thing we look at is what's happening in the pre-index accident situation. So in order to do this, I will comb through the medical records in the pre-index accident periods. And when I come to causation, I'll split it up. I'll look at all the pre-index accident pain issues. I'll look at all the pre-index accident psychological and psychiatric issues. And then I'll look at all the pre-index accident health issues. Now, obviously, what we all would prefer is when you have patients with, a handful of entries in the medical records, and it may be something very simple, skin condition or a bit of anxiety or something like that. But increasingly, what we're finding is patients who have very significant, complex pre-index accident medical records, and this can be a problem. They can have very extensive issues with pain. So a good example is somebody that's been in a road traffic accident that has persistent pain, but when you start to trawl through their pre-index accident medical records, all of a sudden you find that they've had persistent lower back pain, leg pain, they've been off work for a bit, they've had injections, they might have had surgery, physiotherapy, other treatments. And so quite clearly there's not going to be a direct causation there, because they were symptomatic prior to the index accident. Likewise, psychological and psychiatric issues, we need to tease these out by going through the pre-index accident medical records in some detail. And again, you're looking at sort of anxiety, depression, mood disorders, stress, difficulties at work, etc., etc. and then other health issues if they're relevant. So we're really coming down to, well, you know, is this direct causation? Obviously, that is always the thing we would like to find. You know, someone was fit, reasonably fit and well, involved in an index accident or an index event, now has this pain problem, presents in this way. We use the biopsychosocial model of pain, and that pain presentation is directly caused as a result of the index accident. However, as we said, a lot of the time these patients have notable pre-index accident issues, and so we have to take that into account. And it's a case of, well, but for the index accident, really what situation would that patient be in? And it may be, well, they've had an exacerbation, and that may be a temporary exacerbation. For example, our example of the patient with lower back pain, they may have an exacerbation for 6 to 12 months, and we may take orthopedic evidence on that, or they may have a permanent exacerbation. So before the accident, they had lower back pain 3 out of 10 pain score. After the index accident, they have an average pain score of 5 out of 10, that sort of thing. Really, it's coming up with, is this a direct causation? Is it a permanent exacerbation? Is it a temporary exacerbation? The other thing that I've started to do now in my pain reports, and this is really as a result of certainly writing a lot of pain reports, and I've been writing them for well over 15 years now, but in order to give a balanced view to the court about a patient's presentation with pain, again, going back to what we were talking about earlier, the biopsychosocial model. So biologically, the patient has some pain. Again, let's use that lower back pain as a simple example. Psychologically, we've talked about they may have depression, mood disorder, etc., etc. Socially, we've talked about all the issues there. But what I've started to do now is actually look a little bit wider as to why this particular patient may be presenting in the way they are with the pain. So some of the things I look at are in the next slide. Central sensitization, amplifying residual organic pain. What does that mean? Well, that means that is there evidence that the patient has hypersensitivity in the nervous system, which is essentially amplifying the little bit or the bit of back pain they have and making it the experience worse. That's not that common. Don't really see that much in practice or in medical legal practice. The next factors, psychosocial factors amplifying residual organic pain. That one I would dare to say is the majority of these cases, and that's me going on about the biopsychosocial model of pain. The patient has a little bit of organic or biological pain, and the psychosocial factors will amplify that. Next is unconscious exaggeration. Yes, there may well be an element of that. Next, effects of litigation. Unfortunately, the problem obviously with litigation is that the patient wants to make sure that they get their case across, and they're seen as being fairly equal by all the different expert witnesses. What's the problem? We all know the problem. You know, the accident takes place. The decision to undergo litigation may be months or even years later, and then that litigation may go on for years, and the poor old patient has to trot around various clinics and see various solicitors and various expert witnesses, have multiple examinations, and come out with the story and answer lots and lots of questions, and basically is continually reminded of this, but also unconsciously wants to put their story across. Secondary gain, well, you know, you could argue that there is secondary gain in the medico-legal process. Obviously, the main one is going to be financial, and you've got to balance that up. There may also be secondary gain in terms of work. It may lead to less work or avoidance of work. It may lead to not having to do so much work around the home, or doing DIY or gardening, or whatever it happens to be. So that has to be taken into consideration. Conscious exaggeration, well, essentially my way of dealing with this, we're going to talk about surveillance and social media a little bit, but really my way of dealing with this is to say, well, generally speaking, the patients I see have a fairly consistent history and examination findings. But if I find that they have overt behaviours that look as if they're exaggerating their symptoms, I will simply document it in the examination section. You know, if I really think it's obvious. And I mean, recent examples come to mind of a couple of patients that I've seen who've claimed to have very severe pain in their upper limb. They can't do this, they can't do that, they can't work, etc., etc., etc. But at the beginning of the assessment, when they were asked to see their ID, they quite happily, well, one particular person was quite happily unzipped the handbag, took out her purse, and pulled out her photo ID card. So really, you have to look out for these things, and it's not for me to judge, it's for me to notice and for me to document it, and if necessary, make comment on it, because it's important. But otherwise, you know, if I don't see surveillance footage on a patient and I don't see any other documentation, generally conscious exaggeration is not a huge issue. Range of opinion. Now, I've put this in because there are certainly three major areas that I've found in medico-legal practice that are problematic. So the first one is CRPS, complex regional pain syndrome. So as we talked about at the beginning, this is a type of neuropathic pain or nerve pain. You get an injury, and then you get this specific type of neuropathic pain developing, which can be very, very serious. Now, the range of opinion with CRPS ranges essentially from, on the one end, this person has CRPS, complex regional pain syndrome. A step down from that would be this person doesn't have CRPS because they don't fulfill the Budapest criteria. However, they do have evidence of neuropathic pain or nerve damage or dysfunction. So that would be the next step down. And then it starts to slide further downwards, where there is a range of opinion that, for example, CRPS is a psychological or psychiatric condition. Now, this is important because the majority of the scientific literature is that CRPS is a type of neuropathic pain or nerve pain. However, there are some papers which say that CRPS is a type of psychological or psychiatric condition, and there are other papers which claim that the symptoms and signs of CRPS can actually be reproduced by patients, for example, by immobilizing the limb or similar activities. Fibromyalgia. Now, this, unfortunately, in a similar sort of vein to CRPS, with fibromyalgia syndrome, the causation of fibromyalgia syndrome is basically unknown. There are lots of associated factors with fibromyalgia. So some of those would be thyroid dysfunction, psychological things such as disturbance, relationship disturbance, you know, divorce, that sort of thing, abuse, physical, psychological. Some of these patients get funny infections. We've got a number of vets in the clinic that have developed fibromyalgia. They may have had it after some sort of viral type illness. They may have a underlying rheumatological condition. So this is multifactorial, the causation of fibromyalgia. But if you said, well, what causes fibromyalgia? The bottom line is we don't know. We know there are associations. And as we talked about earlier, patients have widespread body pain, they have fatigue, tiredness, sleep disturbance, cognitive disturbance. But unfortunately, a lot of that is self-reported. And a bit like pain generally, it's really a very a very subjective phenomenon, and it's not readily amenable to examination or to investigations. So the range of opinion with fibromyalgia is really, well, does this person have fibromyalgia? Do they have chronic fatigue syndrome at one end of the spectrum? And then again, it slides down to a much more psychologically or psychiatrically based diagnosis. Well, is it not fibromyalgia at all? Has this person got some sort of SSD or somatic symptom disorder or mood disorder, adjustment disorder, or that sort of thing? And often in these cases with fibromyalgia, I will say, you know, well, on the one hand, this person has been involved in an accident. The medical records indicate that they've developed fibromyalgia. They may have seen a rheumatologist who's diagnosed them with fibromyalgia. So the diagnosis from that point of view is reasonable. However, hang on, just again, making sure we're all okay. Yeah. However, on the other hand, yes, there may be other explanations of this, and sorry, I should say they fulfill the American College of Rheumatology diagnostic criteria for a diagnosis of fibromyalgia syndrome on the one hand, but on the other hand, yes, I recognize that there may be a psychological or psychiatric diagnosis that equally or even potentially better fits with the patient's symptoms. So rather than say, you know, this patient has fibromyalgia, that's it, they fulfill these criteria, that's the only explanation, we have to be open to the possibility that their presentation with pain may be better explained or alternatively explained by psychological or psychiatric issues. Surveillance footage, I think we could probably have a webinar or in fact a whole day on surveillance footage, but essentially we see a lot of surveillance footage. More than happy to discuss that further. Essentially what I do is I get the surveillance footage, I look at it quite a few times, then I go through and I will summarize it. And obviously see if that makes any difference depending on the activities of the patient. The other thing we look at these days, we're getting increasingly, is social media. And again, it's a case of interpreting or summarizing that social media and seeing if it has any bearing overall on how you feel that the patient is presenting. Next thing, reliability and veracity. Well, when we're looking at this, or when I'm looking at this in pain cases, I'm really looking at, number one, have they got a consistent history? Is what they're telling me pretty much what I'm going to find in the notes? Does it all marry up? Are they talking about the same thing? You know, for example, is it the same limb that's involved in it, or is it moving around, or is there an inconsistent history? Appropriate examination findings. Well, you know, in this type of patient with CRPS or whatever it happens to be, I would be expecting to find these sorts of findings. Is that appropriate? Pain behaviors, including exaggeration, we've sort of covered that. Next thing is really when we look back at the medical records, are there any glaring inconsistencies in the records? And the real ones that catch my eye are gaps, particularly. So has this person had an accident, not turned up for 2 weeks, 4 weeks, 6 weeks to see his doctor or her doctor, or, you know, did they get better and then there was a big gap in the notes? And the other one, the other big one that we see from time to time is DNA, did not attend. So, for example, a patient who's come to the medical legal process with, let's say, horrific neck pain, and then when you go through the records, you find that they have physiotherapy appointments, but they don't attend them. You've got to wonder why, you know, because that's not consistent or helpful. But at the end of it, I will describe these things in a section on reliability and veracity. But ultimately, I put my hands up and say, well, this is what I've found. However, ultimately, it is for the court to decide. Next, prognosis. Well, I would say this fairly simply. By the time most of the patients with pain come to see me, they're generally speaking, they've had the pain for a minimum of 2 to 4 years, usually often much longer. I think 2 years is quite short, but certainly 3, 4, 5 years, that's quite normal. And usually the pain by that time is relatively entrenched. The patients have had it for a number of years. By definition, if pain lasts for 3 months or more, it is then defined as being chronic pain. So generally speaking, in these sorts of cases, it'll be a case of, well, what's the prognosis? Well, on the balance of probabilities, Mr. Bloggs was involved in the PreIndex accident on XYZ. He's suffered pain symptoms for the last, say, 4 years, which are ongoing. He's had all of this treatment. Unfortunately, it hasn't been successful, or it's made a little bit of difference. And we would finish it with, on the balance of probabilities, Mr. Bloggs' pain is unlikely to spontaneously resolve, because again, once they've had it over 3 months, it's now a chronic pain problem. And certainly once you're looking at this patient 4 years down the line, it is unlikely to spontaneously resolve. What do we mean by that? Basically, we mean that the likelihood that the patient will wake up one morning and the pain is miraculously gone is very unlikely. Next thing, just get a drink, excuse me. Next thing is future treatment. So simple things to say here is that, first of all, it's multidisciplinary. So going to a single practitioner and getting a few tablets or your GP with patients with pain, it's just not going to work. Preferably, if they do have a significant pain problem, they should be under their local pain clinic or pain centre. We always suggest that treatment is done at the conclusion of litigation, and I mean that, you know, that I totally understand there are arguments for interim payments and that sort of thing. My view is that in an ideal world, get the litigation done, dusted, out the way, get the case settled as soon as possible. Then that patient is now free of that, and they can actually concentrate on getting better. That's my opinion. I recognize that, you know, interim payments can be useful, but the problem with them is they tend to draw out the cases, and that, you know, because it may take an extra 6 months, 12 months or more to undergo the treatment, and the patient's still undergoing the treatment under the cloud of the medical legal process. So they still need to sort of, you know, be maintaining that they have a problem. Otherwise, you know, they may be viewed as that their pain has been fixed, and that sort of thing. So let's have a look at multidisciplinary treatment. What does it include? Well, the most important thing about pain is really to break the cycle of pain. So we do this with analgesic medication, so painkillers, different things, anti-inflammatories, nerve pain medications, opiates, weak opiates, that sort of thing. We physically rehabilitate patients, so we try and reduce their pain, and then generally it's physical rehabilitation under the umbrella of a physiotherapist. Next, minimally invasive pain management procedures. These are sort of image-guided steroid injections, use of Botox, radiofrequency, that sort of thing. Psychology, a lot of patients do quite well with clinical pain psychology, where they're taught how to better manage their pain. Sometimes surgery is indicated, and the expert witness in surgery may suggest that. Oh, I'm going to have to move on. We've only got 15 minutes. Equality Act. The Equality Act, well, you're all aware of the Equality Act, and basically we look at the Equality Act and just see, basically, is this person disabled, yes or no? Care needs, we're looking at sort of past care needs, treatment now, future care requirements, simple and complex, and look at the and whether or not they need a care report. And then future requirements, well, particularly for employment, is what were they doing before, how much time have they had off, what's their current situation, and really, what are the aims of treatment? Well, as a clinician and also in the medical legal process, basically, we want to rehabilitate patients. We want to reduce their pain, get them back to work, increase their work if possible, and basically make them as functioning as possible. Okay, there's some of our details there, and I think it's time for questions. So I'm just going to go over to Adam there. Right, so yeah, questions. Anyone have any questions? Oh, one coming in. First question, here we are. Right, so the first question is a spinal cord stimulator good treatment for CRPS or chronic pain? Excellent question, excellent question. So basically, a spinal cord stimulator is a type of advanced pain management procedure. And essentially, it's like a very expensive implanted TENS machine. So you're all aware of what a TENS machine is. Basically, you put electrodes next to the spine. It's an implanted device. The electrodes come out. They fit it into a computer and battery pack, and then you stimulate the spinal cord. If you have a patient with CRPS, and again, this is important, multidisciplinary treatment. If they've had all the medication, they've had the different medications, they've had the physical rehab, maybe they've had some interventions for CRPS, that's things like guanethidine blocks and sympathectomies and that sort of thing. They've had a bit of psychology and they've still got the CRPS, then yes, a spinal cord stimulator may well be indicated. Now, in the NHS, there are two major centres for spinal cord stimulation. The first one is at St Thomas's Hospital in London. The second one is at the Walton Centre in Liverpool. There is actually a third one in Basildon. It's a very large unit. But increasingly what's happening is pain units are starting to do spinal cord stimulation themselves. So, yes. Spinal cord stimulation is available on the NHS, but obviously you've got to wait some considerable time. Patients who are considered for spinal cord stimulation, because it's such an expensive and intensive type of treatment, basically they sorry, lost my train of thought there. Basically, they have to go through quite a process, particularly a psychological process, a screening process. That's what I'm getting at, to see whether or not they're suitable for spinal cord stimulator. Right, question 2. Can you discuss clinical negligence section on page 2 of presentation, as this is where we had a minute of technical issues? Yes, of course we can. Right, let's go back to that. Yes, thank you very much. So hopefully you can see this. So clinical negligence, what I was really saying is that you know, we do mostly personal injury, or I do mostly personal injury. There's no two ways. The clinical negligence, the volume, the numbers of these cases is increasing. So what do we see here? Yes, we see musculoskeletal pain, But the main thing that we see in clinical negligence tends to be neuropathic pain. So this is nerve pain. And the common ones are things like post-surgical neuropathic pain. Somebody's like examples would be somebody's had a hernia operation. Hernia operation technically has gone fine, the hernia's fixed, everything's fine, but they end up with persistent pain in the groin. And they got horrible, nasty, hypersensitive nerve pain in the groin, for example, or they might undergo an uneventful laparoscopic cholecystectomy. What's that? That's basically removal of the gallbladder, but you do it through keyhole surgery. But they can have pain afterwards. Why? Because you've done a technically successful operation, but it's still surgery. You still have to cut through tissues, you still have to cut through some nerves, and patients can get pain after that. The other one is iatrogenic nerve injury, which is kind of a bit the same sort of thing, but this is more, we see patients that undergo sort of very significant spine surgery where, let's say, they've had a lot of metalwork implanted, rods, screws, plates, etc., etc. Recent cases that I've done is where people have put screws through nerve roots and damaged them. Patients have ended up with iatrogenic nerve injury to the nerve roots, or they've ended up with CRPS even. Right, so question 3, these are great. Question 3, do you think treatment should take place after litigation rather than during? Not least because the litigation is a source of stress / anxiety. That is another excellent question. In my opinion, as a consultant in pain medicine, I think we touched on this, I would say that if you have a patient in the medical legal process, the ideal for them is they have the accident, they start their treatment, they get their medical legal claim done and dusted as quickly as possible, if possible, but obviously that is the issue. And then they finish their claim and then they start their treatment with the whole of that behind them. That, in my opinion, is the way of doing it, is to do the treatment at the conclusion of litigation. Now, I completely understand that sometimes it's difficult to give people a prognosis without them having some treatment and seeing how they actually respond to it. So I'm completely mindful of that. But generally speaking, I would say, well, you're better off concluding litigation, having sufficient funds to undergo the treatment that you need, and then you move on without all the stress and anxiety surrounding litigation, and then you move on and you have your treatment. But that's my opinion, and I think that's probably quite up for debate, to be honest with you. I think we could have quite a good little debate. Right, next, question 4. Can CRPS move from the injured area around the body? Oh, the 4th excellent question. The answer is simply yes, absolutely. If you look at the literature, it is in fact very difficult to work out what the percentage is, but the number 7% rings a bell in my mind, because I remember looking at this not so long ago. But the range is insane. It's from sort of 1% through 30–40%. But essentially, if you have a patient that has CRPS, let's say they have an accident and they twist their ankle, break their ankle, they end up with CRPS. They get complex regional pain syndrome in their ankle. It may end up being half the leg or most of the leg, not just the ankle. But yes, it can spread. We don't know why. It's thought that it might happen centrally, i.e. in the brain, that what we call the contralateral, the opposite area of the brain is affected, affecting the opposite limb. But there are some very unfortunate patients that they get the CRPS in one limb, it spreads to the other limb, and they may even going into all 4 limbs. So those are described. As I said, we don't know exactly what the percentage of patients to whom that happens is. I've got the figure of 7% from the last time I looked, but the range in the literature is crazy, and also it's not really reported. that well anyway, the incidence of CRPS and the incidence of spread. So it's difficult to say, unfortunately. Right, question 5. Having treatment after litigation could make it significantly difficult to quantify. How would you get around this? Yeah, I couldn't agree more. I couldn't agree more. I couldn't agree more. And that's really going back to what I was saying about really it's probably a debate is needed as to whether you should do the treatment before or after. Obviously, if you do, the best case scenario is that somebody with a pain problem, they're in the litigation process, they're given an interim payment, they have the treatment, and they have a significant improvement of, I don't know, 50, 60, 70, 80%, and they have some residual pain, and then the case can be settled and everyone walks away and it's all done. Totally understand, and I've been involved in many of those cases and I understand that. The issue, unfortunately, is that you can prolong the litigation process. There may be argument about who or where or how the treatment's carried out. There may be arguments over the funding for it, and certainly I've seen it can get quite disjointed, the treatment that's offered. Because it may be that the case that the patient lives, you know, remotely, they're in the middle of England or the middle of Cornwall or something, or wherever they happen to live. They're not near a pain centre, they're not near a physio, they have to travel for 2 hours to get to a clinical pain psychologist. So, you know, it can be difficult. I mean, one way to get around it is sometimes to send patients to a residential pain program or a residential pain clinic. The only ones really in the private sector for residential pain treatment, as it were, would be the Wellington Hospital, and for a pain management program that's residential in the private sector, there's one in Coventry, which is the Real Health Centre. Obviously, they have very serious price tags attached to them, and then it's a case of how do you get that past the defendant's legal team. So yeah, I think we've identified a subject we could probably talk about as a single webinar. Right, moving on. Question 6. If an injured limb with CRPS is amputated, is there a certainty that the CRPS will resolve? Now, yet again, a very interesting question, and the simple answer is no. And how can I say that? Well, if you say the word, if you say the words medicine, and then you say the word certainty, the bottom line is those two, though, in my experience, the older I get, the more I do this, the more I realize that medicine and certainty don't go together. And certainly if you look at CRPS, we would not specifically be looking at amputation to treat CRPS. I am aware that it has been used. I'm aware that in some case reports it may have been used successfully. The issue you've really got to think to yourself is this: well, what's the contemporary treatment for CRPS? Well, we've kind of gone through it, but let's do it very briefly. It's medication, right medication, physical rehabilitation, mirror box therapy, that sort of thing, home exercise program, blocks, sympathectomies, guanethidine blocks, etc., etc. Stimulation, you might use spinal cord stimulation, that sort of thing. So that's the main treatment, what we call very American paradigm for CRPS. Now, does anyone suggest that you use amputation for CRPS treatment? It's not a recognized treatment modality, but it is used. What's the major problem? Well, the major problem is this: if you had a patient with CRPS, which is neuropathic pain affecting a limb, you then amputate it, you may get into a situation where the patient has post amputation pain. So as we discussed, they have phantom limb pain, so they have pain in the limb that's been amputated, but they could have pain like the CRPS or the same as the CRPS or worse in the limb that's been amputated. So the patient has CRPS, has the amputation, and then ends up with phantom pain, which is the same as the CRPS pain that they had previously. There's more to it than that, but you know, again, that is a debate. Would you amputate or would you not? Certainly something that we could discuss at another time. Right, so what have we got here? So right, that was question 6. That's the last question we've got. All I can do is say thank you so much for listening today. I hope you enjoyed the talk. Last thing is that the presentation and a recording of the webinar we can send to you. That's not a problem. If there are any other questions or anything you'd like to send, please send it to the office. I'm more than happy to try and answer that. I think that's everything. Okay, everyone. Well, thank you very much for your attention, and I hope you have a good day. Rest of your day is good, and hope you have a fantastic weekend. Okay, thank you very much. Thank you.